Well, hello everyone to another episode of Straight Talk. I'm Dr. Steffen Decker, the orthodontic specialist. I am together with my guest today, Hale, all the way from the other side of the ocean, from Texas. And
Hello.
we want to talk today about the importance of myofunctional therapy and the helping devices we have available in our clinic when it comes to the preventive orthodontic space. So, Hale, if you could just introduce yourself, who are you? What have you done in the past? And what is your story, how you as a dentist actually got so engaged in early preventive orthodontics?
Oh, I would love to. Well, first of all, please, thank you. Thank you for having me on. I have been a big fan and I've been looking forward to today for a long time. I am all the way in Texas, so the other side of the pond, and it is hot and muggy and very rainy. So I don't know what your weather's like right now, but ours is not that great. But I am a general dentist. I call myself the airway center dentist, and I actually come from a family of dentists. So I'm one of 5 in my immediate family. My parents met in dental school. I'm married to a dentist, and my younger sister's a dentist. So that's all we do. And I found a passion for early interceptive orthodontics. I did a very extensive postdoctorate education years ago through Vivos Therapeutics. You and I were talking briefly earlier. And I learned everything. It was just absolutely life-changing of what we could do in pediatrics. I actually took the training program in order to learn adults. I knew I was passionate about sleep apnea and I wanted to do mandibular advancement devices in adults, even orthodontic expansion in adults. And I had no intention of treating kids. Truly, I didn't. I paid all the money to do it to help adults because I did not understand the value of what we can do to prevent it from even happening. Like, people had no idea.
I need to stop here because I think some of the listeners don't even have any idea what you're just talking about. That teeth is actually much more than just crowding teeth. So the teeth
Absolutely.
we see is actually only a symptom for far deeper problems that we have to see. So coming to one point, you call yourself the airway dentist.
Yes.
So if I would call myself the airway orthodontist, I might face some struggles where I am because people think, oh God, she's healing or she's just smoke and mirror. So how do you get that name, and what kind of rejection did you get using that name?
Well, so I don't get a lot of rejection personally to my face, right? I hear things in the community. I've heard things like, oh, they're not doing dentistry over there, or she's not an orthodontist, right? Things like that. But I was taking all the knowledge and the literature from 100 years. I mean, books you and I talked about from literally Germany, where you're from, in regards to myofunctional therapy in that orthodontic development. And one of the pioneers in that space in the United States is Dr. Ben Moralia. And he taught me things that I am forever grateful for. I tell him all the time, had I not listened to you speak and taken your course, I would not be who I am today. Because what I needed was the permission and the empowerment that it's easy to do this and I can do it. And I've run with it. I'm not a personality that's going to do something halfway anyways. And when I realized that something as simple as a guided growth appliance, like you and I were talking about, that a patient can put in while they're going to sleep, can correct jaw development. And just like you're saying, like, people don't associate crooked teeth with a breathing problem. And I wasn't taught that in dental school at all. I went to a very, very good dental school in Texas, like a very prestigious dental school. None of the pediatric knowledge that we got went much past stainless steel crowns and sealants. Truly.
So what was the moment where you thought, what did you hear, where you thought, oh my goodness, this is crazy. Why do I not know that? What was this moment for you where you thought, oh God?
It was when I learned that snoring, mouth breathing, and tooth grinding were signs of sleep apnea in kids. I literally sat back and I was like, I was taught to tell parents that the snoring was normal and they would grow out of it. That's what I was taught. And I was saying that. I was saying that to so many families. It's my biggest regret as a dentist, because it's not normal. It's a sign that they're struggling to breathe at night. It's a terrible thing. And no kid should be suffering that. If I can do that feasibly and easily to correct that at age 3 with a mouthpiece, I tell the dads always, like, no offense, but like, they say, how much is this? It looks like a little cheap mouth guard. I'm like, it's going to literally be the best thing your child ever had while they were growing and developing. It will change the trajectory of their life because it's going to change the way their jaws grow.
And I want to mention it because I want to protect you in that airway space well, because what you're claiming to do is not that you basically help if there are massive airway problems, but you certainly can improve certain things,
Correct.
conditions. So
Correct.
basically what we are saying as being focused on airway is that airways are obviously a very complex system where we have bone structure around the nose, we have a muscle trunk, we have
Right.
allergy. So we have a lot of components that are contributing to airway problems. So we are not saying that we are healing everything, but we are saying we can contribute to a big part of the problem together with our team we work with
Right.
to eventually help the people.
Well, and the idea that it's just the Dr. Kelli show is so wrong. Like, as I'm assessing these kids, I'm like, okay, we need myofunctional therapy. You need to see an ENT. We need to have the tonsils and adenoids evaluated. How is your speech? How is your breathing? And the whole concept for me with these guidance appliances is if I can get your tongue up and I can get you breathing through your nose, the magic can happen from there. The systems in the body need to work in harmony. If I can get you nasal breathing and I can get that tongue up, we're going to see that tongue naturally expand the palate and those jaws are going to change in shape. That's when we start to see symptom resolutions. We have the research in the United States surrounding bedwetting, ADHD, and caries rate with the Vivos guides, the tooth pillow appliances that we use. So I already have the literature to back, hey, this is what they use. This is the research and the statistics. So this is what I'm going to offer the patients.
So how hard was it for you to get this team together? Because I know for me in the UK, it was one of the harder things. And like I said, when I first came to UK, I actually gave up on these topics because I just couldn't get anywhere.
Right.
But how hard is for you over there to get these like-minded professionals into your boat to believe in what you say and to not talk a complete different language and talk maybe against you?
You know, in Texas, we have a lot of liberties. It really is different in every state. So I can't speak for every state, but in Texas, the airway movement, if you want to call it that, with the collaboration of the medical providers is huge. Even outside of me, I mean, there's organizations, even in Houston, Texas, that are specific for, we need the hygienists, the myofunctional therapists, the ENTs, the oral surgeons for MMA surgery. Like, that is a huge thing. And they get together literally quarterly. So it's not that, it took me a good year and a half to kind of find like my people that I trusted, you know, because you can't just refer to any ENT, unfortunately. And I can't refer to any orthodontist either, right? Like, it's got to be somebody that we have a mutual understanding of what's proper growth and development for the kids. So it is easier for me than I'd say that it is for you. Although there's a lot of eyes on us now. It's become so popular and so talked about that the dental boards are getting a little bit, having more opinions on the way sleep dentistry and teledentistry, for example, can happen or cannot happen. I would rather they stay out of it, but there's nothing I can do about that. It's happening.
So obviously, as a dentist, was there a point ever in your career where you actually went to an orthodontist and you said, listen, I see these issues in these children I see, would you be able to treat them? And then you got rejected from an orthodontist? Because I hear very frequently that the starting point for dentists actually going into that field was also that they tried to get help with orthodontists locally and they didn't understand the concept and they said, no, we see kids later. How was it for you?
Right. Every time. And so I can remember one lunch in particular where I brought case photos and I was ready and naive enough, I would say, to think that I was maybe going to change his mind or get him on with me or anything like that. And I very quickly realized that it was obviously perceived as a threat in my naivety of like, look at what I did. Look at this before and after. And I didn't even do braces. I did nothing. Like, look, this is like incredible. It was not received well. And ever since now, it's become a burden for the patients because I will see patients that now are coming specifically to me to find out, does my kid have an airway problem? And they're full of brackets. And then I'm like, you've already paid for this. And then we do a sleep study and things are not looking good. And then there's that very awkward sort of interaction. The biggest thing for me in not having that support, I would say, was I had to go learn everything I could about orthodontics outside of an orthodontic residency. I decided that if I was gonna help that patient, I was gonna help them from start to finish. But that's rare. Not everybody can do that. You know, I quit general dentistry. I hung up my drill in 2021 because the need for this, as you know, was so incredibly vast that from infant babies up to, you know, teenagers. And so I think the take home message for that with other dentists that are interested in it is, you know, you've got to have that conversation. But if the orthodontist is sending you a letter asking you to pull the bicuspids, then they're not your person. Like, that's just like, for me at that point, like, more difficult.
And this is for me something very close. So I'm an orthodontist. When I do teaching and training, I speak for my community, which is a specialty community. And
Correct.
it's very clear to me, if orthodontists don't listen to these opinions of people like yourself and are open for eventually change, I know change is sometimes hard, but then they will really struggle eventually in the future with getting patients in the first place. Because
Absolutely.
what I felt, my story was, when I started my own business 3 years ago with no patients, focusing on kids below 10, I haven't had any referring patients for 10 years in London, never, because I was focused on adult market. The adult market is so competitive with clear aligners that
100%.
I'm not getting any referral. Now I'm 3 years in the business, growing my kids' business. Suddenly I get referrals again for children from dentists who do the teenagers and the adults themselves. But with kids, they're actually too terrified because it involves growth and development.
Sure.
So from an orthodontic point of view, our opportunity is exactly to focus on this age group before 12.
Absolutely.
And I think if every orthodontist would understand that, then there wouldn't be much less need for dentists to get all the education in, because they would do what they're best to do, which is cosmetic dentistry, crowns, fillings, whatever they want to do. So, but because we don't listen and we are very closed-minded as a specialty, it forces you as a professional to say, I have a problem, I get a huge demand from kids, I need to do something. If you don't help me, I'm going to do it myself. So it swings both ways.
Absolutely, it does. It totally does. And at the end of the day, the narrative, at least in the United States, is being heavily driven by the parents. I mean, there's so much social media now surrounding education, whether it be accurate or false, on health and wellness and all the symptoms that these kids are dealing with. And when the narrative swings in the point of, you're going to go find the right provider, you're not going to just, it used to be, you did what the doctor said, right? Truly. Like, it was like, if they said this, then you did it. There was not this challenge. I feel like even when I was very little, but now that's different. I mean, the parents that don't know me well too will come in and be like, well, tell me more about this. I'm not so sure. And I love that. I'm like, I want you to be fully knowledgeable and confident in what I'm suggesting, because if you go get an opinion down the street, I promise you it's going to differ, because it will, at least in my town.
I really like what you said. Like, sometimes I have parents and kids, when I start my consultation, they said to me, hold on a minute, I feel like I'm in a school lesson. I said, oh yeah,
Yes.
you are, because I'm educating you. So
Absolutely.
they feel like lesson. And also a very interesting with the mom I had recently, her business was to look at the future technologies, where is it going? And she said to me very clearly, Steffen, our generation, our kids will have all the technology on their fingers, on their wrists, to gain data. So if we have data about our sleep, our oxygenation of blood every day on our phone, and suddenly a treatment is being started where eventually teeth have been pulled and everything's going to be retracted, and suddenly the sleep studies change, the parents and the patient will be very much aware what's going on. So if from this, because the data will be on our fingertips, if doctors choose the wrong treatment plan because they were taught in a certain way, it could really backfire big times to them.
Absolutely. Absolutely. And, you know, in Texas, I can administer a home sleep study. Not every state, almost every state. So I do that. I do home sleep apnea tests on my pediatric patients before and after the expansion. And so I'm like, come at me, but I got the data. Like, I don't know, like, but you're so right. Being open-minded is so difficult when you are in the specialty space. I understand it. I have dear friends in dental school who worked really, really hard to be competitive enough to get into the ortho program. I totally have so much respect for that. At the end of the day, though, we all need to realize that we don't know everything. We still don't know everything about everything. And so to not be more open-minded about this pre-orthodontic intervention and in the way that we can help these kids to behave better in school and be better learners by making sure that they're getting more oxygen at night. It is the most rewarding thing ever.
So I think the biggest problem we have in our communities when you go on conferences, we get taught how a tool is working. So if it's a clear aligner, if it's a fixed brace, if it's a lingual brace, we get taught, look, this is what the device can do. But what we fail to understand is the diagnostic side of things. Because
Absolutely.
if we do good diagnostics, then the
Yes.
treatment plan, the tool actually does not matter. Call it myobrace, call it the Toothpillow, call it lingual brace, fixed brace, a clear lines. It doesn't matter what it is. If your decision based on your poor diagnostic is to extract 4 premolars, the whole treatment is wrong.
Absolutely. So if we could focus on a proper diagnosis, I mean, you nailed it. Whether it's a sleep diagnosis or it's just hypoplasia instead of bimaxillary protrusion, could we just fix the diagnosis? Because if we can do that, and also it's interesting to me, which I love your opinions on this stuff too, but the idea that you can't do mandibular expansion, which I'm very particular in the way I discuss it, because I'm like, okay, if we're uprighting, fine. But I've posted photos where now, when I do my lower fixed expanders, I'm measuring between the lower buys because I'm like, I got to have something to show people like it is safe. The teeth are not being pushed out of the bone when they're a growing and developing child.
Hi everyone, I hope you enjoy our straight talk. If you want to find out more information about the courses we're offering, they're available on our website, theorthodonticspecialist.co.uk, in our course section. And now we will continue with the podcast. Bye.
But that is the growing and developing child. So if you are like in the UK, where patients start being seen from the age of 12, growth and development is gone.
I know, that's too late.
So this is the problem of the whole system. If we talk about changes of growth and development, we need to talk about a period of time where it happens. And also, if we look at the statistics when growth is happening, actually at the age of 5, 6, the growth is nearly as big as at the age of 12, 13.
Yes.
So this crucial time between 3 and 6 is actually very powerful.
It is the most important thing.
So, and this is exactly where people miss so much opportunities in getting the function going, the stimulus going. And if it's just the poor time function, and this is where it gets me, is that when you start at 12, then they have a waiting time sometimes in the UK of 2 to 3 years to be seen. That means they are 15. Number one, they're middle of puberty. They don't want to see an orthodontist. Number two, growth and development is actually gone. It's just far too late to get going. So this time period, which you mentioned, 3 to 6, is the most important time period we actually have.
It is. And the problem though is that forever, my whole generation, orthodontics has just been cosmetic. That's been the whole narrative. And I'm like, it's not cosmetic. It's literally the most incredible, most important thing these kids will ever do. And we have to stop waiting until all the baby teeth fall out. And in the US, it's typically, well, that's, the orthodontic insurance is it's a lifetime benefit. You only get it once. So we just wait till their permanent teeth are erupted. And I'm like, but what about their breathing? And what about their skull development, their arch form, And so I think for a lot of people, I mean, they didn't pay for braces for their kids, our generation, because they couldn't afford it. And they looked at it as a luxury. They looked at it as a luxury for cosmetic and straight teeth. And like, if we could change that to where they knew that primary spacing was so important. And if the kid didn't have primary spacing, then we needed to jump in and do something about it because it was going to change the way they turned into an adult, then that would also help the narrative.
Also, one thing I want to point out, I like one key situation for me was I was trained by John Coyce. And John Coyce sits in Seattle. So how it all started was my wife is a restorative dentist. And when I started working for her, the first question she would ask me was, Steffen, have you seen your cases 30 years later? And I said, no, I'm number one in the world in lingual. I know everything. I'm very good in everything I do. Don't tell me how orthodontic works, but show me anyway. So she showed me the destruction on teeth in adults.
I know.
So then she said, in order for you to work for me, my condition is you need to be educated by John Coyce. So I flew to Seattle. I did all the courses. So I learned everything about functional occlusion and wear of teeth, why it's happening. So at the end of the graduation, I asked John, all of these adult cases you presented here in the course, could they have been prevented by having good orthodontics early on in life? And he said, maybe. So on that day, I came home and I've looked at the cases. So then I had families coming in. The kids were 4, 7, 14, and the parents were mid-40s. They all had the same problem, a deep bite. So what I've seen in a 3, 4-year-old kid was already wear on the incisal edges of the baby teeth and grinding their teeth away. On the 7-year-old, there was minor chipping. On the 14-year-old, we had 2 millimeter enamel loss. And the 44-year-old had already tooth loss. So I could literally show that with age, the destruction continues and it starts at early, as sometimes 3, 4 years old. Exactly, this is the age group where you go in. And I looked on your social media, you had a few cases in there with deep bites. So would you agree with me that this destruction of tooth structure actually starts so much early in life and it's not normal that baby teeth are being grinded away? So how would you feel about that statement that actually the destruction of tooth structure starts really early?
I agree with that wholeheartedly. I tell doctors all the time, we would not have tooth grinding adults if we did not have tooth grinding kids.
That's a good one.
We would not have snoring adults if we didn't have snoring kids. So to dissociate the two, like, oh, this adult just started having sleep apnea, is so preposterous to me because it's the same mechanism of action. We already know that bruxism is a sign of a recovery of the airway. We know that now. We had to fight it. It's in the literature. We know if you're bruxing, you need a sleep study because it means you have an airway problem. It's a response like self-CPR. Why would it be any different in a kid? So if I see that, I'm like, well, I fervently believe that it is too big of a risk to hope they grow out of it. Why would we risk that? I wouldn't risk it in my own kids. I'm going to treat it now so it goes away. And then, you know.
There was a question in the audience we have now. Are there any other signs of tooth grinding apart from sleeping disorder, breathing?
So in my experience, if the child is non-medicated, I would say no. There are side effects to the ADHD medications. They list bruxism on there. So and now, unfortunately, those kids are being put on those medications much, much, much earlier. But ADHD is also a huge symptom of sleep disorder breathing. So I just insist on a sleep study on those. And I know I tend to focus more on the systemic and sleep, which is my training and my diplomates are through the American Academy of Dental Sleep Medicine. So I'm always using that sleep mindset as I'm treating the kids orthodontically. So, but aside from that, even if they were to say, oh, it's stress, which I just hate because it's not true, or oh, it's this, I'm always going to insist if they're not willing to start oral appliance therapy right away, that we do a sleep study so that I can figure out they have sleep apnea and then they need the oral appliance therapy.
So how would you say when you get the statement, which I got in the past, I mouth breathe, therefore my kids are mouth breathing, it's genetics?
Well, I tell them you're absolutely right. And we're very screwed up. So we need to help get in early so that we can fix that. What I have learned is we are about 7 or 8 now generations in of underdeveloped faces shrinking from the genetic component. But really, that's like 40%. Because if we can get in with hard food diet, untethered tongues, and the myofunctional therapy early, your kids' teeth shape might look like you, but their jaws don't have to look like you.
So you just mentioned the point tethered tissue. So what do you do with tethered tissue? Would you say every tongue tie needs to be cut, or what is your
Oh,
approach on
Yeah.
tethered tissue?
So I love that you asked me that because there's so many opinions. I do frenectomies in my office. I've got a fancy laser and I actually had mine done a year and a half ago. I should show you the photo. I had a horrific tongue tie my entire life, but unfortunately I was a product of terrible braces in the early 90s. Okay. Headgear, the back way. They wanted to take the buys. Luckily they didn't. So I have been working to change my style for very many years. I did clear aligners successfully enough to
You have a
widen.
class 4, by the way. Kevin Boyd was a class 4 because I had headgear as well.
Yes, exactly. I love Dr. Boyd. I didn't know you knew him. That's great. But I had to widen in order to have my tongue tie released. So in adults, my theory with adults, I have to have a sleep study first. If I revise your tongue, I always do myofunctional therapy. That's a given. If your dentist is not doing myo before the tongue release, that's a problem. But I will do a sleep study first because you really can make it worse. Like if there's severe sleep apnea and I need to make the palate wider or at least put them into a mandibular advancement device. On the children, I do infants, babies for breastfeeding. And I work with OT and chiropractors always with those cases. But it's about function more than it is me seeing a tie, right? Just because I see one, that's where I lean on my myofunctional therapist, since I have them in all of my practices. Because if they tell me, no, the swallow is great, the tongue is up, like they can reach everywhere, well, then why am I cutting? What am I cutting? I'm going to have more scar tissue. So that's where it's like, no, I'm not cut happy. I'm not just cutting all the tongues. I'm waiting on the confirmation from the myofunctional therapist that something really needs to be done and explain to me why I need to do it, with the exception, of course, of the class 4 really severe ties that are very obvious.
I think there's an important message there because in the media, especially in UK, this tongue tie seems to be a big business and it's been dragged through the mud. And it's really important that the right clinician will always do assessment first, involve a myofunctional therapist with exercises, and only a joint decision that the tongue tie needs to be released, that is then an indication for the release. So also
Correct.
Dr. Sagi is very strict on that. So I think it's really important. It's not meant as a business, meant to establish a good function.
Absolutely. And I hate that. And, the New York Times wrote a really scathing article. You probably read it. It broke the internet one morning. And man, I was putting social media posts out there. The article was actually awful. Like sometimes I'm like, you could have written this in a way that you might have persuaded some of the public, but like it was written so poorly, in my opinion, very degrading to the profession of dentistry, just in general. Like, did you read it? Do you know which one I'm talking about? Yeah. So, but it's, if anything, it allowed a lot of us in the trenches to kind of voice our opinion and what we feel is the best opportunity for the patients. And I think that at the physician level, like the pediatricians, for example, they are not taught the association of growth and development in regards to a free tongue at all. So me, for example, making it as old as I have with a tongue that could barely function, my palate never naturally widened, right? I was a mouth breather, all the things. And had that been on their radar, like, oh, this is really bad. No, this might affect the way she needs braces or whatever. Maybe they would have done something about it. But the narrative is if you can stick your tongue out and you can talk, you're fine. I never had a problem talking. I've been talking since I was out of the room, and so that was never an issue. I never had a speech impediment, nothing, but it definitely changed the way my face grew.
So this is also, when we ask all these questions, sometimes you will see the same thing. You know that there's an issue, but you ask the question, but you're not getting the answers you want. So
Right.
what do you do in these situations? Because you know there's an issue, but obviously you need to find a reason to make the parent aware there is a problem. So obviously we can use technology and draw scans to show pre-contact. We can show high palates. We can show tooth wear. We can show tongue tie. But if the parent sits in the chair with their hands crossed over, but not perceptive to this information, so how do you deal with that?
It's really difficult, but in the beginning, I had that more commonly because I was brand new to it and nobody in the town knew I was doing it, right? It's been different now because people are word of mouth, like you see where they come in and but I still on occasion will get the parent that's just like, well, I don't know if they're going to wear that. And I'm not really sure this is what we need. So what I've been doing for the last literally 4.5 years is every single month, I host a dinner outside of the office, educating patients. And so if I really cannot drive it home in that 30 minutes that I have or whatever, I invite them to dinner. I'm like, and I tell them, I don't think we're on the same page. I don't think you're fully understanding like how much this is needed. I would love for you to come listen and see before and after cases and truly get a feel for how passionate I am about this, because it's not about me. If you want to find somebody else to help you with this, all the power to you. But I feel like you need more education and more information in this. And we fill it up every single month.
So this is also something which is really nice to hear, is that your passion shows through and patients generally feel it. And that's why you grow the way you grow, with word of mouth. But what I want to know now, and saying everyone else who's listening us and listening to the podcast later, is tell me about Toothpillow. Tell me about your concept. What can it do? What it can't do? How do you combine different techniques to achieve the result? Because like, social media shows you before and after, and people might think that a device like Toothpillow can do everything. But I know as an orthodontist, it can't. So now tell me honest, straight German talk. What do you do? What can you do? Where's your limitation? What do you need to achieve your results?
Hi, I hope you're enjoying our straight talk so far. If you're interested in any mentoring or one-on-one session with me to discuss cases or any questions you might have about the treatments of your patients, please reach out to us in our mentor program. We're offering that. We have more information. It's on our website, theorthodonticspecialist.co.uk. And now we're going back to our podcast. Bye.
So, I'm not going to be using a tooth pillow per se on a class 3 case. So when I'm talking generally, the 80% of the population, I'm setting aside the obvious where we need maxillary growth, reverse pull headgear aside. When you take your average child, your average class 2, your average mouth breather, your average high palatal vault, if they're in that 3, even up to 12, but I will give you like 3 to 10 window, I'm going to be focusing on musculature, tongue posture, and nasal breathing. That I'm going to start that, and I'm going to establish that with the tooth pillow, no matter what, even if I know I'm doing fixed upper and lower expanders in the next 6 months. I'm never going to lose that because I'm not going to get correction of class 2 perfectly with just upper and lower expanders. Always. I'm not going to get a perfectly nasal breathing child with a tongue up when they got a bar going across the roof of their mouth. And so for me, I'm going to establish the musculature no matter what all the time first. I have kids now 4 years into their guidance appliance, their tooth pillow wear, that you would literally think I did do some sort of clear aligner therapy or expanders on. And I have hundreds and hundreds of cases. I wish I would have just had a little presentation ready for today, and I could have just gone through more cases. We'll have to do this again.
There's all the information on your Instagram.
It is. There's many, many cases on our Instagram. And I always list, if I did something besides a tooth pillow, I will state that. We did clear aligners. The one I posted today with the crazy lower arch expansion was upper and lower expanders with the tooth pillow, because I'm always using them together. And then I did clear aligner therapy. So I try to be very clear.
Let's stop you here. That is something which is really important to understand. You combine two different tools within the treatment. So basically you're using the power of active tooth movement with an expander or bone expansion while you correct the function, the soft tissue around it, with the tooth pillow. And this is the brilliance, the genius in you, where you combine different techniques. And as a good clinician, this is what orthodontics is about. Whether we don't follow strict protocols, we have been learning for 20, 30, 50 years that we try to engage our brain and combine different techniques to get where we want to be. I think this is super important to understand.
It is, yeah. And for me, it was like, okay, if I'm not going to do bracket and wires, because in the beginning, that was not on my radar, because I wanted more chair time. I wanted predictability. I wanted to give them the case. I wanted to give them all the aligners. I needed more chair time. I still need more chair time all the time. I need more chair time. Just like you were saying, with any sort of removable early intervention products, there's a lot of education, a lot of appointments. And was delivering a upper expander on a patient that was a really, I mean, I think the overjet was like 12 millimeters or something. Okay. Like a really severe class 2. And I was like, I wonder if my guy, and he was wearing the guide, the tooth pillow. I deliver immediate. We take records. Here's your tooth pillow. The expanders have to get made. They'll be here in a month and a half, whatever it is. And I thought, I wonder if it will fit over it. Because if he could accommodate both, then I'm protecting his airway while he's sleeping, which is what's going to make him feel better quicker than expanders. You're going to feel better after expanders, but it's going to take a little bit, right? Like and I put it in and he goes, yeah, it fits great. And I was like, it was like this moment where I was like, oh my God, this is going to be the difference. And do I have to use a Herbst? Do I have to, like, I'm going to use this in all of my protocols. Now I get them to a certain width and I have to stop using it because it's too small. I was telling you the starter is about 35 millimeters. So once I get them wider than that, then I got to take it out. And at the end, they go into that tooth positioner borne appliance that I showed you. So
and you can show the people again. I think people are not aware what we are talking about.
Let me just pull something up really quick. Yeah. I will do that. And so that I can show you what they look like. But I was going to tell you, because the tradition is you go into retainer, something fixed, obviously, to hold, but I go into the guided growth appliance that is meant for all of the teeth. And that's where I get a lot of correction in the tooth alignment, but also
I have a question there, because obviously from a tongue function positioning point of view, the tongue wants to go to the palate. So now you have an expander in your palate plus a tooth pillow device. In the palate, where's this tongue sitting? How do you get the tongue function going with that?
Well, you'll get some lifting in the posterior, but that's not my point in using it at that point. I have it in there in order to get condylar remodeling to correct the class 2s. So when the guide is in over the expanders, the tongue's not doing the job, right? Like,
so basically you stage what you want to achieve. So you focus on the condylar growth in that stage, and later when you remove the expander, you go to tongue positioning.
Correct. Yes.
Yeah, so again, the device is not doing everything at once. It does it in stages. You need to identify which stage is your priority, because obviously we know from condylar growth, we have less time than doing the tongue function and positioning.
Correct.
Right.
So this is the picture of one of the starter pediatric appliances that we were just talking about. This is for all primary dentition. These are the Vivos Guide appliances, which is also what we use in Toothpillow. And then these are the more advanced appliances for orthodontic movement. So that actually calls for active wear. So that's going to be an hour to 2 hours during the day, clenching, stimulating that growth and change. This is my retainer before going into phase 2 orthodontics.
So does it have a custom-made imprint of the teeth in there?
It does not. So what it does is it does the widths of 7 through 10, and I fit that chair side. And that is
7 to 10 means in English language, upper right 2 to upper left 2.
Yeah, sorry. Yeah. Just good old Texas dentist over here, 7 through 10. So we take the sums of the widths of those 4 teeth, and all of those appliances are designed to be the fit for the child and what their width would be at that time. So it's an old school way of doing that. But it's a beautiful retainer for me that I know I'm not also restricting any of that growth while I'm waiting for the phase 2. Let's say mixed dentition. If I'm waiting on more permanent teeth to come in, I don't want to put them in a retainer. That retainer's not going to work that entire time as teeth are falling out anyway. I will put them in that appliance, and then I'm getting alignment at the same time.
So this is super interesting, because when I'm between phase 1 and 2, obviously there's a problem, teeth falling out. We can consider fixed retention in the front, but that might basically block the movement of laterals when the canines start erupting. There were discussions about passive aligners. There's discussions about through retainer. So actually, but what your device is actually doing, it shields the cheek muscles, the lip muscles, and gets the balance function so that the jaw development is going. So I think actually from a retention point of view between the face, this is a brilliant idea.
Thank you. I wish I invented the appliance, but I didn't. But I am an avid believer in them. And it just makes our job so easy. Like, literally, I'm like, these parents think I'm a genius. And I'm like, I love what I do. I was like, but this is really the power of the appliance. And when you say, what are the limitations of it? Seven, I'm telling you, like, when it is worn, it works every time because the kids are growing. The key is when it is worn. I have never not had one work. And
so
if it doesn't, I put in.
So now we come to the most critical question I have for you. How do you engage compliance? How do you motivate these kids over these period of times to be motivated to wear it? Because I'm in central London, the people are spoiled, the kids are spoiled, they're having 10 million activities. So when I was in the Swiss countryside, it was very easy to motivate the children. But in London, with all the activities, it's much harder. So what do you offer them in helping tools?
So I'm very bossy, okay? But with the little ones, we do lots of sticker charts and rewards. We really do. And also, I think it's important that when I'm doing these checks on these appliances, it's either myself or my airway assistants. I've trained a big team to help me, like you said, we had more chairs and more time. But I'm holding the parents accountable, but I'm also holding the children accountable. And when I tell you I have bought them gifts before, I'm like, if you wear this like you're supposed to, it's not going to be a cheap toy out of my toy box. I'm getting you something off of Amazon. Like, I'm not opposed to bribery, right? But when the kids that are symptomatic are feeling better, they don't stop wearing it. I mean, when I'm focusing on, okay, you have night terrors, I have never had a child still get night terrors when they're wearing their tooth pillow. I can say that with 100% certainty on all of my cases. So I'm like, if you're getting night terrors, that's going to stop when you wear this. And it motivates the child. My biggest thing is a lot of kids don't want expanders if they don't have to have it. So I'm like, okay, well, I'm literally going to glue something in your mouth and you're not going to be able to take it out if you don't wear it. But I think, unfortunately, in dentistry, like the educating brand new dentist that's getting into it, they use that as an excuse to not offer the treatment because they don't think the kid's going to wear it. I don't have the patience for that, because what I tell the parents is the consequence of you assuming they won't wear it vastly outweighs what's going to happen if they don't wear it. Like, you have to, I tell them it's as important as taking a shower. Do you let your kid have an opinion about whether they take a shower? Then they don't get an opinion on whether or not they wear their tooth pillow.
Oh, that is so important. I totally agree with you. And do you have, like, I know MyoBrace, for example, has this app available for them, showing them exercise. Do you have something similar to educate the patients or to motivate them?
Yeah. So with our virtual tooth pillow company, the entire process is built into the app. For my private practices, it's that they're paying a higher fee to see me, rightfully so, in office, and they're coming in. We have on staff Myo. We have these assistants that are trained extensively in the process. So we have this open door. Anytime you need something, anytime your kid's fighting you, anything happening, they don't like the taste, they don't like this, whatever, bring them in, let us talk to them. And so I think the more we as the dentist understand what's normal, they're going to spit it out for the first couple months. They are, or they might not, and that's great. But it's also super normal if they don't keep it in all night. When we know enough to know what's normal and what's the kid being ornery, you're going to be a better clinician for that parent, because those checks are really for the parent, because it's me asking the parent, what have you been doing? Is this working? How can I help you? Do you need me to be stern? What do we need to do? How can we motivate the child?
That's cool. And do you have parents, like when I started the MyoBrace journey as well here, I had sometimes parents who researched me because I'm offering MyoBrace, and they had the feeling that everything can be corrected with MyoBrace, and they were very demanding exactly what they want, how they want it, how much time they want to spend it, and what they want to be achieving with it. So what do you say to these parents?
I tell them that there's only so much that I can control behind the scenes. I'm not at your house every day making sure that you're doing your nasal hygiene and that your kid's doing their myofunctional therapy exercises, but that I know what is possible in the changes if they do what I tell them to do. But I'm not responsible for the success of the case. I've given you the tool, and I've given you all the tools that you need in order to make this successful. But I do tell them I do take ownership of the case. And if I am not happy with our progress by the time they're getting to the 12-year age, then I'm going to be putting in hardware, because it's my professional opinion that phase 1 has to be done right. It is what we've been doing wrong for a century, in my opinion. And if when that child leaves my care and we're done with that phase 1, I'm going to make sure their jaws are fully developed, no matter what tool it takes me.
Yeah, because after it is purely cosmetic.
Absolutely. And somebody's going to screw it up if I don't do it.
Yeah, and all the orthodontists will be angry with you because you took away their job.
I know, I don't care anymore, but you're right. I understand. I'm like, so do it, so offer it. That's what I always say. Fine, I have too many anyway.
I agree with you. There are enough children out there. So you mentioned one thing which I'm not familiar with so much yet. You talked about the nose hygiene.
Oh yeah.
Tell
So
me.
really big on that. I use pure saline. You can use X Clear. That's one of the bigger brands because it has xylitol in it, which is antibacterial. So that's good. It will really help with the shrinkage of the adenoids. So when they've been a chronic mouth breather, the tonsils are big, the adenoids big, everything's angry. It's part of our processes that they do a spray, blow before bed, then they put their guide in. So I want all this clear of all the gross stuff so that they have the best chance of keeping it in all night while they're sleeping.
So that's a really important part which we shouldn't miss. So basically we're clearing out the nose so it enables them to better use their nose when they use the device. So this is again this whole care process of making sure it's not just a device you're giving a kid and forget about it. So it's also really important to understand the parents need to be involved in that because they need to supervise their kid doing it. So it's not a device where parents are out of responsibility and they can just give it to their nanny or their childminder or whoever they are. They should sit with us together in the boat. Otherwise, this whole concept of prevention is a bit much more difficult and the expectations are not there.
They are.
So I think this is super because this is where I have a lot of struggles in London when I have first consultation of children and they're coming in the first consultation with their driver. And I said, where's the parent? So where I see from the get-go that there's no engagement really from a parent side. They just come, oh, okay, I should check my child, but they're not really interested in what their child has. Because the information they're getting from us, not tooth-related, which is airway-related, health-related, all the things, this is far too overwhelming for a childminder to communicate with their parents. And I had a case today, just now, where the dad came in. Sometimes, you know, the dads, they just track their kids to the appointment because the mother told them to.
I know, and they never know what's going on. I'm like,
and they never know what's going on. So half an hour after the appointment today, I got an email, oh, can I have a Zoom meeting because I wasn't in the appointment because I was working.
Oh my gosh, yeah, for $500. I'm just kidding.
I said, where were you in the consultation? I mean, why would I give you now another consultation? Just come to the consultation in the first place.
I know. Well, you know, those kinds of situations, I think that's when the dentist has to make the determination, is a removable appliance therapy an option here, or do we need to do fixated appliances? Because if you've got an 11 or 12-year-old where you're on the fence and they're not going to be compliant, you don't want to miss your window either.
Yeah, I mean, this is now where I have the biggest struggle when I start them too late because they're coming too late. Like aligners and all these things, it becomes very complex because I demand the compliance of these teenagers and I don't get it a lot of times because they don't see the sense. As soon as the teeth are better, they lose the compliance because they're okay. So this is, again, the most valuable patients we actually have are the patients below 10 years old. And this is the market that is most missed out on. It's just unbelievable how dentists, orthodontists, pediatric dentists don't see this huge opportunity for us to grab that market. And it is, and when you go through these stories, like you mentioned night terrors, I have a few stories which I can tell about kids with night terrors where we did early preventive orthodontics with clear aligners and we solved the problem in a few weeks. So it makes you actually emotional.
Right.
It's why? Because you actually change their kid's life in a very short period of time, you know, but with the expansion devices, when you mentioned tooth expansion expanders, you were talking about tooth-borne expanders. Am I right?
Correct. That's what I'm talking about, the non-surgical options.
So basically, you're not talking about the hybrid expanders where you go with tats into the bone.
Correct. Not with me. Not that I'm against them. I have somebody for that. But me personally, correct.
So again, from an orthodontic point of view, they need to listen to this. So again, you are so experienced in this preventive orthodontics, but you won't do a palatal bone expansion device. Versus we at orthodontists, we should be offering that because that is our expertise. So again, this is where our joint venture can come across, this collaboration between an airway dentist like yourself and us as an orthodontist. Even if you do all the preventive measurements early on, that's fine because we're all helping the community. We all
Right.
help these children to develop. And trust me, there are millions of children out there who need the help, who have been rejected. So together in a team approach, this is the way forward. We should stop getting our elbows out and thinking for ourselves. Like when we wrote the business plan for our new practice 3 years ago, we were calculating the kids in a 5-mile radius of our clinic. So there are about 25,000 children. So, but fact is that children now traveling hundreds of miles
I know. Oh my
to
God.
see me, which
Right.
makes me feel bad. This is
Right.
why me personally, I started opening the academy now in our practice, because I felt like it can't be that people traveling 4 hours to see me for a half an hour consultation. If I can train an orthodontist, a dentist, or pediatric dentist in that area
Absolutely.
to do what
Yes.
I do, and I even
That's so
mentor them
smart.
and help them to grow, that is
Right.
much better care for these patients in that area. So we are not saying, both of us, I'm sure you agree with me, we are not saying we want to solve every kid's life. We want to create a community of like-minded people to
Yes.
connect these people to become powerful. Because you're in
Absolutely.
Texas, I'm in London. We are
Yeah.
far away. There are a lot of miles between us. And for some reason, we are so happy to talk with like-minded people
I
thousands
know.
of miles away. It
I
cannot
know.
be the case that we have to travel hours and hours to find colleagues who think the same way. There's
It is.
so much need in our community, in our children. It
There
comes to
is.
our own children. And I
Yeah.
always say to dentists who might not believe me the first time, imagine your princess would sit in that dental chair and would struggle to breathe with night terrors, getting bullied at school, and struggling to concentrate at school, being hyperactive. All of these symptoms we see day in, day out in our clinic related to sleeping disorders. If that would be your princess, would you not want to do something about it?
Absolutely. You're so right. I mean, I have not met a parent one that would not choose something else besides medication. They're on the medication because that's what they were prescribed, and they were at their wits' end. They had no other option, but I need to help my kid. Okay, I'm going to try this drug. And then we realize that we're medicating our kids because they're tired, because they're not breathing well at night, and they're not sleeping well at night. And you and I can fix that. And the parents want it. They need the information, and there needs to be 15 of us in every city.
I want to talk lastly about this Toothpillow remote, this whole remote process. What was your idea behind that? What made you choose to do it? What's the philosophy behind it? And what do you want to achieve with it?
Education, awareness. I want it to be a household name. I want the public to demand a tooth pillow, whether they're getting it virtually or they're getting it in your office or my office. The more the public and the parents know about the treatment options, the more it's going to drive that, oh, well, the patient's asking for it. I'm the one that looks dumb because I don't know what it is. I should get educated on this. But it was to increase the access to care and reduce the cost a little bit, because the cost is very expensive in office, rightfully so. It's expensive for expanders, it's expensive. Orthodontics is one of the highest expenses in kids, sometimes aside from college, right? So I will share the website with you because this is so important. And we did have a question on one of the doctors, and I pulled the picture up because she wanted to know if I could speak on the differences between the different appliances. And I can generally. I'll show you on here. Honestly, Dr. Raval, if I'm saying your name right, I'm very agnostic when it comes to appliances. When I'm mentoring dentists, if you have anything that looks like this, I'm happy. Put it in the kid's mouth, get them breathing through their nose. But this is my favorite. And for one big reason, this is the tongue tab. It's stimulating the tongue to go up. Lots of appliances have that. But the thickness of this occlusal pad, that specifically, compare it to the other ones, okay? Hold them in your hands and you'll see it's much thicker. So I'm correcting those deep bites in 8 weeks because of the disclusion that's happening when it's in between the teeth. But this is our website. And we don't have a teens and adults option yet, one day, but in the kids space, ages 3 to 12, I wanted the parents to be able to find a website that was talking about poor jaw development and what it meant and all the different signs and symptoms that can happen from that, because they're not associating malocclusion with sleep disorder breathing. They don't, that's not a link. That's common knowledge. Crooked teeth is not sleep apnea. So we spent so much money and so much time showing photos of the profiles and what happens, you know, poor tongue function, and there's less breastfeeding now, and just the you know, the domino effect that can happen. And our hope was to increase the access that the kids would have to an airway dentist. And then I'm in all 50 states with the most powerful airway dentist minds, some ortho, some general, of how can we fix this? And can you guys help us remotely? Because we can assess the kid as needed with orthodontic photos, a proper medical history. We do an easy online assessment. They meet with the doctors virtually. There's all these custom videos, and it's been a huge, huge passion project of mine for the last 3 years. And we've had some influencers as of late find out about us and post about us, which caused us to go viral, which was scary, but wonderful at the same time. And we use a mixture of appliances, you know,
But
between
it's also what it comes down to. It creates a community of clinicians who have the same mindset of helping children and to educate, because I totally agree with you. The biggest barrier I have is I'm so passionate like yourself that I want this message to get out there to as many parents as it can. But this podcast now will be maybe looked at a few hundred times, but there are millions, billions of people where this message needs to go out there. This is hopefully just the beginning of something. And just briefly to the end, I know Mike Mew, and the word mewing has been looked at 13.5 billion times now.
Amazing. I know.
So
I do it.
Yeah, so I know social media is a very powerful tool, and I congratulate you on the website you've done here. I think the mission is great. If I can support you in any way in that mission, me as an educator, I try to do with the courses to try to teach dentists, orthodontists, pediatrics to be different, to have the guts to be different, because being different is sometimes hard.
Absolutely.
And sometimes you have to have a lot of education knowledge to withstand the pressure. But if you speak to your patients and you listen to what they say to you and what you change in their lives, you will be rewarded in that way. I can promise you, and you can promise you the same way. So thank you so much. I think we talked, I don't know how long, but forever. It was so nice that you took your time today. So I'm sure everyone in the UK is tired by now, but talking forever. Thank you so much. I really appreciate your time. Let's keep spreading the message together. And I hope we can do something in the future together.
Oh,
Thank
me
you so
too.
much.
As soon as we're cleared for Toothpillow in the United Kingdom, you're going to be our person. So I'm so excited about that. I really want to come visit you. In all seriousness, my husband and I,
my doors are open.
I would just love to. And it's an honor that you asked me to be on here, and I hope everybody gets something out of it. And I look forward to collaborating with you in the future.
Thank you so much. Have a nice evening, everyone.
Have a good one, guys. Take care.
Take care. Bye.